So good morning, everyone. Thank you for the invitation. Thanks to Annette who invited me, and she asked me to provide you some insights into the global epidemiology as well as WHO European region and European Union epidemiology. As Claudia mentioned, I'm from the Robert Koch Institute, which is the National Public Health Institute in Berlin, in Germany, under the umbrella of the Ministry of Health in Germany. Okay, next slide, please. Or can I do this? I can do it. I have no disclosures. And starting with the global situation in 23, because 24 data is not around currently, in 23, nearly 40 million people are living with HIV worldwide, and the majority of them were adults, and 1.4 million were children. But more than half of them were women and girls. And 86% of all the people living with HIV knew their status in 23, but 5.4 million did not. And in 23, that was the year with the fewest people acquiring HIV newly than any time since the mid-90s. And that were globally 39% less than compared to 2010. When we look in women and girls, 76% of all women with HIV have a suppressed viral load compared to only 67% in men. And that means if women are linked to care, they are better linked to care than men. And the new HIV infections dropped by 50% among girls and women compared to only 44% drop in boys and men between 2010 and 22. But girls and women are at a disproportionately high risk of acquiring HIV, and they are carrying a high disease burden because of sexual violence. Women are still underrepresented in clinical trials and HIV research programs, and the access to PrEP is historically developed in MSM. And so women still remain underserved with information about and access to PrEP. This picture shows you, is from 22, and it shows you 20.2 million girls and women living with HIV. And the different colors are shown the different regions of the world. And the size of the bubbles are showing the proportion of women and girls infected with HIV in the different countries. And when we look into the light green, you can see Eastern and Southern Africa. And here we have South Africa, which is mostly affected. In Western and Central Africa, that's Nigeria and the Democratic Republic of Congo. Then in Asia, it's India. Then the United States. In Western and Central Europe. In Eastern Europe, and Central Asia, definitely Russia and the Ukraine. And in Latin America, it's Brazil. Again, when we look at the global situation, as I mentioned, we have a change in the new infections by 39% since 2010 globally, and that drop you can see in the blue bars in the different regions of Africa and also in the Caribbean and Asian region. However, in some regions of the world, especially in Eastern Europe and the Middle East, we are observing an increase among new infections in 23. Now I would like to go to the WHO Euro region, and that means Western Europe, Central Europe, and Central Asia. And the three maps shows you the different transmission groups, MSM, heterosexual transmission, and people who inject drugs. And when we start on the left-hand side with MSM, you can see that in Western Europe, the HIV epidemic are centralized MSM epidemics, and that is completely different in the region of the former Soviet Union, which is deeply red for the heterosexual transmission group and the people who inject drugs. Because after, with the beginning of the 90s, the epidemic started there among intravenous drug users and swept over to their partners. And then it spread in the whole population, and that's why this is deeply red. And among those heterosexual transmission groups, there are also a lot of people, we call them the so-called bridging groups, which are mostly MSM, who are, because of stigma, are not disclosed their sexual orientation, or labor migrants or sex workers. When I come to the European Union and the EEA states, which is Norway and Switzerland, heterosexual contact is the most common mode of transmission among all HIV diagnoses. That were 8,250 in 23. And 1/3 of these diagnoses were among people who are born in the country where the diagnoses were notified. However, 2/3 of the new diagnoses were among migrants. And heterosexual transmission rose from 41 to 46% in the last 13 years. And there was also an increase among women from 21% to 25% compared to that of men. Now, I come to the threats which are in danger, that drop we observed in 23 among new infections. And one of the most important threats is HIV-related stigma and discrimination. And when you look at this slide, you can see the number of countries with discriminatory and punitive HIV-related laws globally in 24. And you can see that many countries, 156, still criminalize or have criminal laws against HIV non-disclosure. Then we have criminalization of transgender people, 13 countries, and that countries are increasing as we are learning today. And criminalization of any aspect of sex work is also in many countries around. Then same sexual acts in private in 63 countries, and the possession of small amounts of drugs is also criminalized in most of the countries of the world. The other threat is the impact of the United States shifts on the global HIV response. We have that 90 days freeze of funding, which is affecting the lives of a lot of people living with HIV because of cutting in the organization of the support to the global AIDS response. Healthcare workers are losing their jobs, testing services are closed, and PrEP and PEP and ART and condom supplies interrupted. And on the right-hand side, you can see a picture from the PEPFAR-supported countries, and you can see most of the 39 countries are reporting disruptions. And in 2 countries, Haiti and Ukraine, there's almost dangerously low stocks of HIV medicines around. Another threat is the Russian full-scale invasion to Ukraine, and I mention that because a lot of neighboring countries to Ukraine are affected by that war, and Ukraine is a country of high prevalence of HIV, with estimated 250,000 people living with HIV there, and they have an epidemic which is driven by intravenous drug use with 20.5%. These numbers are from 21. And you can see the map on the right-hand side, which shows you the different regions in Ukraine. And the dark ones are that with a high prevalence of HIV. And you can see that are in the south of Ukraine, and that are the regions which are now occupied by Russia. And this map is from May 22. You can see in the red and orange regions the HIV testing services in AIDS clinics, and a lot of them were closed already in May. And that means you have no treatment supply, you have a high within-country migration in the Ukraine, and the ART supply is interrupted. And as I read on UNAIDS website, the PEPFAR-funded TLD batches, they stranded somewhere in Poland, and there are negotiations how to transport the medication to Ukraine. However, the CAP-LA PrEP pilot is financed until April 26. The Ukraine is the only country where that pilot is around. And currently there is a gap for 30,000 treatment courses for 3 months in 25. So these are the threats which are threatening the benefits of our fight against HIV. And let me allow you now to come to Germany, to my country, which is in the middle of Europe. And, sorry, I go back. No. Sorry. No. Oh.
Wrong way.
Excuse me. No, back again, please. Back. Yes, thanks, Germany. Okay. A short fact sheet about my country. We have 83 million inhabitants, 16 federal states, and more than 90% of our people are members of a statutory health insurance. However, the access to health care for non-insured persons is not regulated in Germany, and we have a very fragmented healthcare system, so data analysis is often difficult. And our newly diagnosed cases in 24 were 3,250 newly diagnosed HIV cases. We have more male than female cases. And we have heterosexual transmission is rising in Germany. And that is because we have a high number of people migrating from Ukraine to Germany. And we have 576 cases with a linkage to Ukraine. However, that decreased compared to 22, and we think we still underestimate these people from Ukraine because a lot of them are previously positive and they are aware of their HIV status. And when they visit an HIV treatment specialist in Germany, they were not tested again. So this is an underestimation. We have also a high proportion of late diagnosis in every transmission group, MSM, people who inject drugs, and heterosexual transmission since more than 25 years, and that did not change in none of these groups. We have 32% and 38% and 33% of late diagnosis with low CD4 cell counts and 18% AIDS-defining diagnosis. And among women, that is mostly true for women from sub-Saharan Africa, and especially for women from Southeast Asia, because these women have really no community in Germany. We also estimate the number of undiagnosed HIV infections, and that simply should show you that the proportion is also highest in the heterosexual group on the bottom, and that is also true for women from sub-Saharan Africa. So, and what is about prevention and PrEP use in Germany? Who are the PrEP users in Germany? More than 98% are MSM, and more than 90% are members of a health insurance, more than 60% using it daily, and 20% on demand. And it's very well established in the metropoles like Berlin and Hamburg. It works very well. We have a very low HIV incidence among the PrEP users, below 0.1 per 100 person years. And by the end of 23, we are estimating around 40,000 PrEP users in Germany, and that covers around 50% of MSM. But where are the women? And I calculated a so-called PrEP to need ratio, which is an indicator for PrEP use and PrEP need in a population. And when we are estimating 20% of our newly diagnosed cases were female, the PrEP to need ratio in 23 was 16.8 among male PrEP users newly diagnosed with HIV, and only 0.8 for PrEP users among newly diagnosed females. That means men are using PrEP 20 times more often than women in 23. And what are the barriers? The barriers for the population beyond MSM. And the population beyond MSM are women. Women are a very diversified group. There were trans women, sex workers, migrant people, and people who use drugs. And there are a lot of stigma and myth around, also in my country, and the biggest myth is that PrEP is not allowed for women. A lot of doctors do not know that they are able to prescribe PrEP to women. And PrEP is also highly medicalized in Germany. That means a specialized HIV treatment physician is only allowed to prescribe it. And if general practitioners will do that, they have to train themselves and go to HIV treatment specialists to learn it in online courses or, yeah, like this. So I come to my summary. So women were predominantly diagnosed late with HIV infection in the WHO Euro region and the European Union. If women are in care, they are better linked to care. The biomedical prevention, PrEP, is a very most promising tool for women, but there is less information about PrEP among women, and there's less awareness among prescribers for PrEP use, especially among gynecologists or general practitioners. There is no approval for injectable PrEP in Europe except for Ukraine, that pilot project, and there's a lot of stigma and myths around against PrEP. And the procurement cuts and shifts of the US funding are threatening the success in the fighting against the HIV epidemic. And I thank you for your attendance, and that is my institute, Robert Koch Institute in Berlin, which was founded for Robert Koch himself, and with the cherry trees in blossom before, and I also thank my team at Archives. Thank you so much.